Well, folks, you are in for a treat today. I have the infamous, illustrious Dr. Vivek Subbiah with me on the Healthcare Unfiltered podcast. If you don't know Vivek, you're in trouble because you must know who he is. But he's going to introduce himself to you in a little bit. And really our topic is a little bit more developmental therapeutics, a little bit of precision medicine, precision oncology, and trying to understand what that field really looks like today and what it might look like in the future. Vivek, welcome to the show. I really, really appreciate you taking time of your busy schedule. I know that you have a lot on your plate, so carving out some time to come on the podcast means a lot to me and to listeners. But let's talk about you a little bit. What you do, what you work, all of that stuff, and really what got you a little bit, who influenced you to be into oncology, into doing what you're doing right now?
Chadi, thank you so much for having me, and thank you so much. I know in these pandemic times, it's been challenging, but it's been a pleasure and to follow you on Twitter and other social media, to interact during the major meetings. So I'm a faculty and I'm associate professor currently in the Department of Investigational Cancer Therapeutics, which is the phase 1 clinical trials program at MD Anderson. Also, I'm the medical director of the Clinical Center for Targeted Therapy and the executive director of cancer medicine research for the MD Anderson Cancer Network. So currently, my role is to run early phase 1, phase 2 basket studies. I'm a PI of over 30 to 40 clinical trials. My research interests are in drug development in rare cancers. And my real interest has been leading several first-in-human and practice-changing novel basket studies. The first ever histology-independent basket study, I was fortunate to be a part of that, which was the vemurafenib basket study that led to an FDA approval for vemurafenib, which is a BRAF inhibitor in Erdheim-Chester disease, which is an extremely rare disease. And following that, I served as the global PI for the rare oncology agnostic research, which in this case we used a combination of BRAF and MEK in cancers of unmet need that harbored a BRAF V600 alteration. And we saw phenomenal responses in this aggressive cancer called anaplastic thyroid cancer, and this became another practice-changing study. So this was the first FDA approval for this deadly cancer. Most recently, I was fortunate to lead 2 selective RET inhibitor trials, selpercatinib and pralsetinib for RET-dependent cancers. So last year, in 2020, not 1, but 2 RET inhibitors got FDA approved for the treatment of RET fusion positive non-small cell lung cancer, thyroid cancer. And in addition, I was also part of the lurbinectedin registration study for small cell lung cancer, and also part of the pemigatinib, which subsequently got approval for cholangiocarcinoma. In addition, I have, because of the developmental therapeutic work I do a lot of radiopharmaceutical studies. And, one of my first ever radiopharmaceutical study was radium-223 for osteosarcoma, which was the first ever investigator-initiated study that I wrote as a fellow. In addition, again, these are the stuff I've done. But, my main thing is that as a major advocate for precision oncology,
we're going to talk about that.
Yeah.
But Vivek, you've said a lot of big words that I want to try to dissect and simplify, because
Absolutely.
some of the listeners may not be obviously as well versed in what you are saying. Mm-hmm. So my philosophy is simplify. So you said basket studies. For fellows who are listening, students, or even people who are not in medicine, what are you alluding to?
So there are 2 types, at least, of precision oncology studies. One is the umbrella study, and the other one is the basket study. The umbrella study is focused on one particular tumor type, wherein, for instance, we take lung cancer, we sequence lung cancer patients. If they have an ALK aberration, they go on an ALK inhibitor. If they have a BRAF aberration, they go on a BRAF inhibitor. That's an umbrella study. One histology, multiple arms, basket study is a histology independent study design, wherein the patients could have any tumor type, but as long as they have their tumors harbor a single alteration. For instance, our road basket study. So patients with any cancer that harbors a BRAF V600E alteration, like anaplastic thyroid cancer, GIST, hairy cell leukemia, any of those patients will be eligible histology independent, but based on their genomic genotype. That's a basket study.
Very important to clarify that. The other thing that you mentioned is, because I'm trying to set the stage into some of the tough questions I'm going to ask you. You come on Healthcare Unfiltered, there are no easy questions here.
Absolutely.
One of the other things you said is precision oncology. And, there are two things, like when people talk precision oncology or precision medicine, one could say we always have done precision medicine. We try to treat the right patient at the right time with the right drug. I don't know, pick your chemotherapy of choice. 5-fluorouracil is what, like a pyrimidine analog or something that, Taxol, it targets something in the cell cycle and the tubules, microtube, whatever it is. So is it just like precision oncology, a little bit more fancier way of what we're doing with chemotherapy?
Not necessarily. See, the thing is that the chemotherapy paradigm is a traditional paradigm, wherein we take a drug, we treat patients with a particular cancer and try to look for a response rate. So precision oncology or precision medicine, right, in the right sense, is targeting a biomarker, targeting a genetic alteration, and delivering the right drug to the right patient with the right biology at the right time. Let me give you a brief overview. The fundamental premise of oncology, indeed all of medicine, is that every disease, even an untreatable one, warrants a diagnosis. The light microscope that was invented in 1500s is still used to diagnose cancer. Peering at the surface of the cells to determine the tissue of origin renders a diagnosis. If there's a patient that presents with a lung mass, we do a biopsy and we take it and see those cells under a microscope to say if it's non-small cell lung cancer or small cell lung cancer. However, if we are able to improve our ability to treat cancer, we must supplement the centuries-old technology with the molecular microscope. And this is precision oncology. Genomic testing permits interrogation of the inside of the cell and definition of a tumor's precise coding sequence. And again, personally, I believe that genomics is the diagnosis and is the most powerful argument for its universal use, that every patient afflicted with cancer deserves a diagnosis. That is precision oncology.
I remember a viewpoint you wrote in JAMA Oncology. It's actually one of my favorite ones. I forgot the title, but it's almost similar to this, that every patient should be sequenced or kind of thing. But I wanted to answer two things for listeners again. One is when you say sequencing, and again, please don't take us into basic science bench research, because then I'll lose the listeners and they'll take a nap. A little bit, just briefly, how you do that, like what do we mean by sequencing? But really the more important question that people might ask, why should I sequence if I don't have a drug for every mutation I may find? So, there's a concern is, sure, I'll sequence, I'll identify these aberrations, and I'll end up using carbotaxol. Of course, clinical trials are different because you're doing clinical trials, you may have drugs, but let's say somebody general in the community who's not doing clinical trial, that's often what we hear. So let's talk about what you do to sequence the tumors, And then, is there a benefit to sequencing if you might detect so many abnormalities and then you're stuck with saying, well, what am I going to do with this information? I really don't have drugs that target this particular gene.
Yeah, absolutely, absolutely. So, to take it to, the basic level, let me precisely then define precision medicine. So this is an emerging approach, for disease treatment and our prevention that takes into account the individual variability in genes, environment, lifestyle for each person. Again, I think this is something, the definition of precision medicine that is there in the NIH as well. And it's a form of medicine that uses information about a person's genes, proteins, and our environment to prevent or diagnose disease. What is precision oncology? This is a field in oncology defined by customizing treatment to an individual's molecular profile. And we'll also be talking about biomarker. So what is a biomarker? It is a characteristic that is objectively measured or evaluated as an indicator of abnormal biologic process, a pharmacological or biologic process to a therapeutic intervention. So let me give you why we need precision oncology and why we need a lot more research in precision oncology. We are still scratching the surface of precision oncology. We haven't really deployed precision oncology in the real world. So between 2003 and 2013, there are several cancer drugs have been approved by the EMA and the US FDA. But unfortunately, the total mean improvement in survival, in overall survival, was only around like 3.4 months. Routinely, we see that new medicines that confer an additional survival of mere weeks to even days with just statistical p-value victories are hailed as major breakthroughs in oncology. The randomized clinical trial, considered as a gold standard for clinical trial, has failed to render cures or long-term survival for majority of patients suffering from advanced malignancies. In 2021, in diseases such as metastatic pancreatic cancer, 90% of the patients are not alive after 2 years of diagnosis. Diseases like glioblastoma, 90% of the patients are not alive after 3 to 4 years of diagnosis, despite a multitude of traditional randomized control studies. The high cost of these conventional trials, the large number of patients receiving futile therapy on control arms, and the lack of biomarker selection hampers progress. So the questions you ask, makes me, take a step back and talk about the amazing genomic and immunological breakthroughs that we are seeing in oncology. The pace of genomics and immunological breakthroughs in oncology is accelerating and making it likely that large randomized studies are increasingly become outdated before their completion. The control arms become completely useless, at the time when the trial is published. Traditional clinical research practice paradigms must adapt to the reality unveiled by genomics.
So how do we do that though? I agree with you. I think, we can't really keep doing clinical trials like we've done 5 decades ago, right?
Yeah, absolutely.
So when you say adapt to the genomics, because, you still have, help me understand what you mean by you don't need to do randomized controlled trials anymore, and you need a new paradigm. Elaborate on that a little bit.
So, rather than one size fits all monotherapy, I think we need to take a step back and think about precision oncology. The central tenet of precision oncology paradigm requires, again, I keep repeating this again, delivery of the right drug at the right time to the right patient. Again, the current model of precision oncology, what we have right now, usually matches single agents to patients with late stage refractory, molecularly very complex disease. And this is suboptimal. Optimizing targeted therapy requires a departure from traditional paradigms. deploying gene-targeted agents earlier in the disease course when the tumor is less complicated at the genomic level, and administering immunological agents to patients with complex cancers harboring mutations that, like for instance, with high mutational burden, and also moving away from monotherapy to customized combinations. Again, genomics just represents the tip of the iceberg. In the future, and I fervently believe that panomic testing that includes transcriptomics, proteomics, metabolomics, and immunogenomics will paint a more complete molecular portrait of tumor. Again, you ask me.
But there's no question. I agree with you.
Yeah,
it will paint a better picture of the tumor. No question, right?
Yeah.
There's no question. It's like when you have a house, you can describe, this is a big house, nice yard, looks great, versus you describe the bathroom, you describe the living room, you describe the dining room, and you're more like the everything, right?
Mm-hmm.
You're describing the house versus everything in that house. No one would argue with that. The pushback that you get is, okay, shouldn't you try to demonstrate or prove that by knowing that molecular underpinning of the tumor and treating based on the knowledge of that molecular underpinning improves the lives of people or patients compared with treating them without that knowledge? So, if you take in a randomized fashion, or is it what you're proposing that because the era has changed, you really cannot do randomized controlled trials in that setting? I'm trying just to understand the point of view you're bringing up.
So let's go back to the history of precision oncology, right? So, we usually use the word magic bullet, right? So 100 years ago, I think it was Paul Ehrlich who introduced the concept of magic bullet cures in oncology. Again, for 90 years, we didn't realize that. Until maybe a couple of decades ago, we had the first, targeted therapy, which is a real targeted therapy, imatinib, which, targeted the altered BCR-ABL kinase, which is pathognomonic of chronic myelogenous leukemia. Again, CML became the poster child for precision oncology in liquid tumors. Before the imatinib era, the median survival was 4 years. Today, the life expectancy approaches a normal lifespan, provided that treatment is started at the time of diagnosis. Delaying treatment, even for the CML patient, until late-stage disease, as what we do as standard of care in solid tumors, delay the treatment until late-stage disease, renders even the breakthrough targeted therapies for CML ineffective. See, early successes of precision oncology has been the Herceptin for HER2-positive breast cancer, and EGFR for lung cancer, anaplastic, lymphoma kinase inhibitor in alkebulant lung cancers. And again,
don't forget my Rituxan for lung.
Oh, absolutely.
Oh my God.
Yeah.
Oh my
absolutely.
God.
So all of which have significantly impacted the outcome, but albeit not to the extent seen in CML. All right. So what we have today, we have massively sequenced the genome. All right. The sequencing cost of a single human genome has dropped in a breathtaking manner from $3 billion in 2003 to about $1,000. You can get it as low as like even $500 in some countries. And hundreds of actionable aberrations have been discovered. Thousands of drugs with novel mechanism of action, including gene-targeted therapy and immunotherapy, are being identified. Yet, we have just witnessed a few triumphs in oncology. The thing is that I would never say never. The thing is that, let me give you an example. So when I started, this job in 2012, when I saw a patient with a BRAF alteration, I would be happy. When I saw a patient with ALK aberration, I would be happy. When I saw a patient who had say 30, 40, 50, 60 aberrations in 2012, 13, I thought, oh my God, these patients are done for, and I wouldn't be able to target these patients. Fast forward 5 years, Right now, if I see a patient who has 30, 40 aberrations, I get excited because these are the patients that respond amazingly well to immunotherapy. So never say never. So, you mentioned, genomic testing is not just for matching to targeted therapy. It provides diagnosis in many instances. It can provide prognosis, right? Many times we can also think about drugs which we should not be giving patients. For instance, genomic testing, if it shows a KRAS, we should not be giving cetuximab to these patients. And if we find a BRCA alteration, we would do genetic counseling. So it's diagnostic, prognostic, and has genomic implications as well. And so, science is rapidly evolving. And so it's the best time to be in oncology. Of course, the worst time to be in oncology as well, given the complexity of who's going to pay for it and stuff. But the science is so much fascinating. Again, 10 years ago, even when I was doing my training, I don't think so immunotherapy beyond ipilimumab was just approved when I was finishing my fellowship. And immunotherapy is the ultimate example of precision treatment. Checkpoint inhibitors activate the immunomachinery. Still, we don't know why it works amazingly well in some patients and does not work well in many patients. And these checkpoint inhibitors enable the innate ability of the immune system to recognize and destroy the tumors. So the immune system is both personalized and precise. And we also realize that the immune apparatus distinguishes malignant cells from the normal cells. And we are finding alterations like PD-L1 amplification associated with a 90% response rate in Hodgkin's disease treated with PD-1, or a very, very high mutational burden, or a mismatch repair defective patient. Immunotherapy offers striking responses in these patients.
I like what you mentioned about there are certain elements in knowing the molecular profile that might tell you not to use a particular agent. I think you brought the KRAS as an example. I like that you mentioned it might provide prognostic value, because I do think sometimes the prognosis, identifying the prognosis, is rather critical. I think that what people might say who are listening to this, I think they might say you're being a little bit unfair by presuming that what we have currently in the new therapies match what we're talking about Gleevec. I mean, Gleevec is a home run, let's face it. I mean, right? I mean, you just said when you have someone who gets Gleevec, these patients have almost a normal life expectancy. And, it's really not what you see. Even in many of these targeted therapies, you see pretty modest progression-free survival. And sometimes we don't know about overall survival. So I guess my question to you is, if we don't have studies, how can we define the benchmark of what we're trying to improve upon? For example, pick your mutation and pick your drug. Is 4 months enough? Is 3 months enough? How do we know the actual incremental value if we don't have a comparator arm? I'm just trying to understand, if you were today to design a clinical trial, and you're you're an excellent trialist. I mean, I can't believe you have that many trials in less than a decade from fellowship. It's crazy. I mean, we're going to get into that because it's crazy. But how would you design it in a way that A, the patients will hopefully benefit, B, you really are able to be certain that what you are seeing is incremental compared to standard of what people are doing? I think that's really where people struggle. The skeptics, I would say, might struggle in trying to understand. So what do you tell the skeptics about precision medicine and sequencing?
No, absolutely. So there are two things. One is the question about, the first is a question that I need to resolve that's still lingering, that you asked, is about the randomized study. Of course, there was a randomized study done in precision medicine. It was called the Shiva trial. Right? Yep. The Shiva trial was negative.
Yep.
And it was often mentioned as an example to bolster the argument that precision medicine is a failure. So my point of view is Shiva trial is important as it demonstrated that a randomized precision medicine trial could be conducted. And I'll stop at that. However, if you closely read the paper, approximately 80% of the patients in the Shiva trial were matched to single agent mTOR or a single agent anti-hormonal therapy. So from the Shiva trial, it is reasonable to conclude that matched monotherapy in terminal patients with an mTOR or a hormonal modulator in the advanced cancer setting is not effective. The corollary, for instance, in that trial for RET, right? We have phenomenal therapies for RET. We have selpercatinib and pralsetinib approved last year, and I see those patients every day in clinic benefiting from treatment. For RET, they matched imatinib for RET. Imatinib does not target RET. So that was the match in Shiva. For RET patients, they matched imatinib. So it is reasonable to conclude that matched monotherapy with these agents in refractory patients is not effective. The corollary that all precision medicine is a failure extrapolates a finite observations in the trial to setting that were not adequately explored in Shiva trial, and hence is not a justifiable argument.
Are there some other studies like Shiva that are ongoing right now?
There are like a couple of trials that are ongoing, but let me take a step back and explain what we need in precision oncology. Again, it is one of the major stumbling blocks in precision oncology is that there are intrinsic and acquired resistance mechanisms to targeted therapy, and all these trials are being done in terminal cancer patients. One drug matched to a driver aberration may not be realistically be expected to cure patients or achieve remissions if each tumor has a distinct and complex alteration, right? So the more we sequence patients, all these patients are malignant snowflakes. Every patient's genomic makeup is different. Mm-hmm. You pick up every commercial profiling report, you pick up every Caris report, you pick up every Foundation Medicine report or an MD Anderson or Sloan Kettering report, right? Each patient has multiple genomic aberrations, right? They are malignant snowflakes. So one drug matched to just one of the mutations may not be realistically expected to cure patients. Other drugs must be added to overcome resistance. So the paradigm of individualized therapy means that the traditional way that drug regimens become standard of care no longer will work. Yeah. Canonical drug development paradigms are drug-centered. The drugs are the focus of the study, and each patient enrolled receives the same regimen regardless of the genomic or the phenomic heterogeneity. However, what we see here is each tumor is different. Just like our faces are different, our fingerprints are different, each tumor has a different molecular fingerprint. Yeah. So we may need to test thousands of regimens in increasingly small subsets of patients. Indeed, let's take this example. If there are 300 drugs in oncology, we try to combine them. There are 45,000 at least 2-drug regimens and 4.5 million 3-drug regimens. The traditional clinical trial design model breaks down. Hence, this conundrum is unsolvable in this era. So precision medicine implies that patient-centered trials and care should be done. The patient should be the focus, and drugs can therefore vary from patient to patient. In this model, what I'm envisioning, it is not the drug regimen that is evaluated, but rather the strategy of individualization that is evaluation. So then the question comes, what is the standard of proof for this strategy? Right. And that's why we need to think about out-of-the-box ideas in the era of precision oncology, that new clinical trial designs may be needed to evaluate a personalized care performance so that standard of care guidelines can include and emphasize and even mandate customized individual treatment. So the one-size-fits-all approach in oncology, in the traditional model, is still an anomaly.
That's a paper me and you need to write. What would be the clinical trial design in precision oncology? But let me ask you this, Vivek. So some of the drugs that you were instrumental in approving and led the clinical trial effort that led to the FDA approval, were they approved based on surrogate endpoints and on the accelerated regulatory pathway? Like
Yes.
we talk
Yes.
about
Yes.
RET inhibitors
Yes.
and all of that, right?
Yes.
So generally speaking, the accelerated regulatory pathway mandates post-marketing studies to demonstrate that there's a survival benefit or there's a clinical benefit that was promised based on the surrogate endpoint approval in the accelerated pathway. So how are these trials being designed? Take us through an example of any of the drugs that you led through the accelerated pathway using a surrogate endpoint. Tell us, what was the surrogate point? What was the outcome? And then what is the post-marketing trial that the FDA is watching for? Because in the post-marketing trial, you have to have a control arm, I mean, at some point, right? And all accelerated pathway drugs, by law, I mean, they're mandated to have a post-marketing trial. So, you know, because it's so difficult to design, I mean, we're forced to design in the post-marketing studies. So can you give us an example into what type of post-marketing trials are being designed for these agents that have been approved in the accelerated pathway?
Oh, absolutely. I think, you know, I've mainly led, you know, genome-driven biomarker studies. So I can give the most recent example of, you know, selpercatinib and pralsetinib. And let me take an example of the selpercatinib because that was approved first in the disease course. So what we saw was, you know, we saw in the primary analysis set, like RET fusions are seen in, let me go to the basics so that everyone understands here. So RET fusions are oncogenic drivers in 1 to 2% of lung cancer, 10 to 20% of papillary thyroid cancer, 60% of sporadic medullary thyroid cancer, and 100% of hereditary thyroid cancers. And beyond these non-small cell lung cancer and thyroid cancers, which are RET fusion and mutation driven, we see a tail end of RET fusions, less than 1% across all tumor types, pancreatic cancer, colorectal cancer, and multiple other cancers. So when you know, this was originally designed as an early phase 1 study, dose escalation study. We started as a phase 1 study. And, you know, we saw phenomenal responses in RET fusion positive lung cancer and RET aberrant thyroid cancer right from the second dose level. In fact, right from the first dose level. And, you know, we haven't seen, you know, such, you know, I can say this is a unicorn, right? We don't see such responses. I'm a phase 1 clinical trialist. We don't see such responses across the board. And, you know, seeing these, you know, phenomenal responses, either the phase 1 study was expanded and amended to a large phase 2 trial design, where phase 2 basket study design, where each arm enrolled you know, X number of patients based on an interim analysis. So eventually, in the primary analysis set, 105 patients with RET fusion positive non-small cell lung cancer were enrolled. And the overall objective response rate was 68%, with 2% CR and 66% PR, including a 91% you know, intracranial response rate. And, you know, this was seen in patients who were treated with platinum chemotherapy, and patients responded regardless of immune checkpoint inhibitor, you know, and prior receipt of multikinase inhibitor. So these are previously treated patients who did not have any options, right? Post-platinum, there are minimal options for lung cancer patients. And these patients
so the surrogate endpoint in this trial was overall response rate?
Overall response rate. So because of this, and then that was you know, the refractory cohort. And then the other cohort was, you know, because, you know, these patients were doing well, you know, patients who were not eligible for platinum-based chemotherapy or patients who wanted to get on a targeted therapy upfront, 34 patients who were treatment naive, that means who did not receive immunotherapy or chemotherapy, were also enrolled on this clinical trial. The response rate in the frontline treatment naive setting was 85%. So you can see that post-platinum, post-IO, in fact, IO does not even work in these patients. The response rate is 68%. And the treatment naive population, the response rate is 85%. We saw phenomenal response. So in the final, a total of 144 patients. In the prior platinum, the response rate was 64%. In the previously untreated patients, the response rate was 85% in a total of 39 patients. And the median duration of response was 17.5 months. So since this was active post-platinum, and it was active in the refractory and the naive setting, FDA approved based on this data. And the overall survival was not even reached because the patients are still on the study. But we still continue to follow on the study.
Right, but did they approve?
So yeah, exactly, post-marketing, right? Although the FDA does not, in this case, in these biomarker-driven cases, the FDA does not require a future randomized study. The randomized study that is being done is any patient in the front line, any patient with RET fusion non-small cell lung cancer will be randomized to a RET inhibitor, a selective RET inhibitor, or standard of care with chemotherapy plus or minus immunotherapy, standard of care. So again, what we saw from ALK, right? I think these arms, especially for these novel targeted therapies in lung cancer, they're going to crush the chemotherapy arms. I think we should extrapolate from what we saw from the ALK and the EGFR, driver mutation subsets. Again, these are just 1 to 2% of lung cancer, and I'm thinking, we are, again, the trial is being done, but personally, I would feel that we are comfortable in giving this selective RET inhibitor to a frontline patient, seeing these responses.
Oh, very good example, and thank you for sharing that with us, Vivek. That's really nice example. And it's a good, the question is, it seems like the FDA may not mandate always post-marketing trials for these.
Exactly. But as you see, the controversy is now for drugs, for that Alzheimer's disease drug, and also for checkpoints that are being approved without a biomarker, right?
Yeah.
So they receive accelerated approval based on single-arm data, and the post-marketing randomized study failed to, beat standard of care, but still they remain to be approved, right? So that is the area of controversy that that may take time for it to settle down. Yeah,
I'm gonna say I think it's also really challenging to enroll to a randomized trial. Look, I'm thinking if you are in the 1 to 2% of patients who really had this RET fusion.
Yeah.
If you're in the 1-2%, how happy are you going to be being randomized to a chemotherapy versus knowing there's an actual targeted therapy that really works for this specific mutation? So I'd say it's not easy to do a randomized trial like this, honestly. And I think kudos to all patients who are willing to undergo randomization for this to try to answer an important scientific question, because I could imagine that will be a very uneasy field. Hopefully that there's access to the new drug at the time of progression and there's a crossover.
Oh, absolutely. There's definitely a crossover. The thing is that it'll be tough, to accrue in the US. So this has to be, these are global studies. And again, RET inhibitors are not approved in many countries, right? Yeah. So if these trials are global, the trials can be done. Of course, in many countries, the trial will pay for standard of care therapy as well. So I think, it'll be, one way or the other good for the patients.
So Vivek, I don't know if you know the answer to this, but it got me curious when you mentioned some of the patients that you end up sequencing and you have like 40 mutations or whatever. How easy to develop drugs for mutations that don't have drugs for? At some point, 20 years ago, obviously RET fusions existed. We just did not have drugs and we never really checked for them. right now we check for this. So when you identify these mutations, is it easy to go back to the lab and try to manufacture a new drug and develop a drug that targets this mutation? Is that, I mean, how long does that take? Like, is there a process at MD Anderson? Are you guys involved in that piece, or is it mainly manufacturers and biopharma? Take us through that.
I think that's a great question. And I think the more we sequence patients, the first step is one of the most important things is when we sequence patients in the real world, we will know the length and breadth of the genomic alterations that are prevalent in the general population so that we can make drugs for it. And, we need to expand the druggable genome. So, we have RET, MET, AKT, ERBB2, FGFR, FLT3, IDH1, IDH2, mTOR pathway drugs, BRAF, NTRK, NRG1, PI3K. And there's a whole another field for homologous recombination deficiency, like the BRCA1, BRCA2, PALB-B2, RAD50, ATM, RAD51, CHEK1, 2, and then we have the EGFR, we have TSC1 and SMARCA1, 2, 3, and so many alterations being developed. In 2000, so I can give an example for the RET. 25 years ago, RET was one of the first fusions or rearrangements to be cloned. And at that time, there was no treatment for that RET. But in 2012, RET fusions were discovered in lung cancer, just in 2012, all right? And 2014, I believe, RET fusions were discovered in colorectal cancer. And 2017, we had 2 RET inhibitors, selective RET inhibitors in clinic, in first-in-human clinical trials. 2017, we started the phase 1 study, and 2020, we got 2 drugs approved for these patients. And 2021, we have another 3 selective RET drugs, a couple of them next generation drugs that can help. So again, when we have the identify these genes, a lot of researchers in major academic centers and pharma companies, work on, who are working on in structural biology and drug discovery, come up with novel kinase inhibitors. I think, right now, today in 2021, we have better technology than we had 2 years ago and 3 years ago. So the next decade is going to be phenomenal in drug development, right? Not just kinase inhibitors. There are protein degraders, there are molecular glues, and the whole new field of antibody drug conjugates. We had antibody drug conjugates, of course, in hematology, but again, the technology is developed and the sequencing is developed. Now, the drug structure and how they make the drug, the structural biologists, they have started using artificial intelligence to identify drugs to fit the right allosteric pocket. So for instance, KRAS G12C, yeah. KRAS was undruggable. Like right now, it's up.
I'll tell you a funny story. I was a first-year fellow, I'm not going to give that. No way. But no way I'm telling you. When I was a first-year fellow and I was listening one of the grand rounds in NCI, I was a speaker from the NCI. The entire talk about KRAS and how it's impossible to target the whole talk was how RAS is an awful oncogene that nobody really can target and so on. And look at where we are now. We target the KRAS and all of that.
Yeah. Again, there are 30 targets now, promising genomic targets, right? This list is only the first iteration of a continuous process.
Is your sense that you can combine those? So for example, I know some mutations are mutually exclusive. Like, if you have a RET fusion, you may not have something else and so on, all of that stuff. But not all of them are as such. When you have a tumor that might have several targets, is there a sense that you have one of them that is the main driver that really leading to the cancer progression, where this is the one to target, or they all equally important? You have to use 3 drugs, each one targets both, and you have to do a trial for that. How do you look at that?
Again, that's a good question. So the thing is that, of course, even in these patients, right? Even in these, patients, for instance, RET fusions, we haven't had complete response in all patients, right? We see partial responses and maybe a handful of complete responses. And, we need to understand, first, tumor is complex, right? We need to know more about, still our understanding about so many things is very nascent. We need to understand first about tumor growth, right? These scans are still primitive. We need to have dynamic monitoring. We need to have better functional imaging studies. And also, the drug resistance could be from tumor burden, tumor heterogeneity. How do we overcome the tumor heterogeneity is early detection. Again, we are diagnosing cancers and we are trying to treat cancers in the late stage when they have complex genomes. So that's why we need to have early detection. And of course, customized combination therapies. Customized combination therapies can definitely impact upon. But the challenge is, you might ask, how are we going to combine them? Do we need to do a phase 1 study in every patient, right? So right now, what we practice in the day-to-day clinic is one-size-fits-all treatment model. I think the one-size-fits-all is an anomaly. In daily medical practice, physicians always use customized combinations, especially in non-malignant conditions, right? A patient with diabetes, like say heart failure or rheumatoid arthritis, receives a set of different drugs. None of these diabetic drugs, if there are 3 diabetic drugs approved, and my uncle is on 2 diabetic drugs and 3 different antihypertensive drugs, it was never tested as a phase 1 clinical trial.
Right.
But the general medical practitioner is able to combine them in the clinic, right?
I think toxicity is a little bit an issue, probably. It's just
exactly. So the average patient enters the oncology clinic with an approximately 8 to 10 drugs tailored to their specific health problems. And these individual combinations were never tested in phase 1 studies, yet physicians safely and effectively administer them on a regular basis. So in oncology, I think we have a cultural precept that if a new drug combination has not been tested in phase 1 studies, it should not be used because the safety is not known. And this is a legacy or the vestige from the cytotoxic era, since combining cytotoxics could have serious safety concerns. Again, the modern anti-cancer drugs like immunotherapy or targeted therapy have very few prohibitive overlapping adverse effects, except a few. And our understanding of drug combinations has grown, and one size fits all is not the norm in medicine. And since advanced cancers and cancers are heterogeneous, it should cease to be the norm in oncology care. Again, these can be controversial for what I say. We don't even practice this in clinic, but I feel personally that this is what we got to do if we need to make, advances in oncology. Again, I read on Time magazine that even with the current rate of research and new drugs, what we do in oncology, it'll take another 1,200 years for us to cure cancer. Because unless there is some major breakthrough, every decade, like immunotherapy or something, it's going to take a long time.
I'm not sure it'll ever cure all cancers. It's just, people have to die of something. I mean, maybe the pragmatic person in me.
Exactly.
I'd love to cure all ailments, not just cancer, heart disease and strokes and everything. I just don't see that everybody is going to age and live forever. Maybe we'll see. Vivek, you've been first of all, you've been very generous with your time and telling us about all of this. I want to just give listeners a personal flavor of who you are, because you've had really a wonderful career. I follow you and your achievements and what you're doing, and it's amazing what you've accomplished, in my opinion, again, in less than a decade since you finished your fellowship. How did this happen? Because, part of this is definitely your passion, your dedication, your hard work. But were you influenced by somebody? Did you get lucky with certain things? Did somebody mentor you? Just tell us how. It's a little bit unusual. It's a very, very wonderful, successful academic career, but it's not really a usual trajectory for many academicians. Who do you attribute this success to?
So,
Vivek, don't forget to mention your wife, buddy.
No, no, absolutely. Again, I got, let me thank from high school days. I think I need to thank my mom and grandpa, who were very instrumental in motivating me right from day one. All right. I always used to push things and do something different. In fact, I don't know if you may know, I'm both I'm both board certified in medicine and pediatrics. I did med-peds for residency.
I did not know that.
And I'm a pediatric oncologist and a medical oncologist. I did both. I did dual training. Here at MD Anderson. Again, I wanted to do both. I loved kids and take care of adults and kids. So I did dual training for residency, and then for fellowship, there were a few programs that offered both. And in fact, there's no program that offers. We have to make it up. So MD Anderson has both the pediatric and adult medical oncology fellowship. I did that. And then, of course, I came here, and I was influenced by, I would say, several people here. Several mentors. Primarily, first in my fellowship, I was mentored by Pete Anderson. He was here. He was a pediatric, adult and pediatric sarcoma doctor. And Dr. Jeannie Kleineman in pediatrics. She was a basic scientist she discovered one of the first immunotherapies that was approved in osteosarcoma. Not many people know. It's called mifamurtide. It is approved in Europe and Mexico and many other countries, not in the US. I think, 20 years ago, it was approved for osteosarcoma. It was the first immunotherapy. And then Dr. Russell Kurzrock, she was here. She was leading the phase 1 clinical trials program, histology independent clinical trials program. And Dr. Emil Freirich. Dr. Emil Freirich was here. And I was fortunate to directly work with him as the GME administrative fellow, had a lot of FaceTime with him, used to chat a lot with him. And, again, these are the people who primarily shaped my early career at MD Anderson. In fact, I had, my research was varied. I had research in leukemia, in germ cell tumor, in sarcoma, in pediatrics. So again, I interviewed so many people, in fact, to get on to do lab. And it was Dr. Kurzrock. She said, you have so much energy, you want to do so much. I think, let's do all this. I think, she was a nice, she was a great mentor, because she said, do what you want to do. If you're passionate to do something, go ahead. I think she gave, instead of thrusting their agenda in you, I think they let you, such mentors let you do what you want to do, and give you space, time, and also channel you in the right direction. And I think when I finished my fellowship and I started on as faculty, I think Dr. Kurzrock retired from here and she moved. I stayed back on. And my mentor, guide, and philosopher here was my wife. She was a fellow here. She matched here for MD Anderson as a hem-onc fellow. So I was with her, and she was my mentor. I think she was my friend, philosopher, and guide. It is challenging when you transition to a new faculty. Especially everyone in your department is very, very senior, and you're the junior most person there. It's a challenging time, but I think it was the best and worst of times. I think, and then, subsequently we had our, chair here, who was a visionary as well, Dr. Funda Merrick Bernstein, and Dr. David Hong, who recently led the KRAS. I think they've been of great support and encouragement to what I really envisioned and what I really want to do. The thing is that MD Anderson is a phenomenal place. I think the patients give a lot of motivation. The patients give hope, and as you know, we all live in hope. We all live our lives in the future. We base most of our decisions on experience of the past, but we have a limited ability to envision the potential for major changes in the future. And, consider this, like 30, 40 years ago, the outlook for patients with coronary artery disease, was 100%. And this has declined to less than 10% now. In many fields of medicine, there is continuous progress. We see that in COVID. COVID was what? In March, January last year, in 9 months, we had a drug. We had a vaccine. Of course, we are still working on therapeutics. We have a vaccine. I think, in cancer is in such a phase. I think we need to work, everyone needs to work diligently and aggressively, like people worked for COVID, to get cancer treatment for every patient.
You're doing your part. You're doing a great job. You're doing your part, and you've been extremely productive, influential. I think, I don't know, you probably, I stopped counting, but you're close to 10 drugs, I believe, that you were really instrumental in bringing to market. And there are no questions that some patients' lives have been saved because of your efforts. And really, I think we're very proud of what you're doing, Vivek, and just continue the good work. Any last thoughts before I'll let you go back to your mentor?
Oh, thank you so much. Thank you for the wonderful opportunity and space. It was really fun to talk about this. Sometimes you talk to someone and they ask questions, then you think aloud about the topic. And
we still have to think about writing that piece. You got me thinking about this clinical trial design. I don't think it's an easy question to answer.
No, it's not an easy question. I think for myself, and what we are doing right now is not the way. If we are going to move the cancer needle up, I think we need to do a different model of clinical trial design. And
I'm just putting, I just put myself in the shoes. I understand. I mean, I'm a big proponent of randomized controlled trial, but if I really have that 1% to 2% mutation with that specific drug that targets that mutation, am I comfortable getting another agent on?
Exactly.
So anyway, I think there's a lot of food for thought. I'll be curious to see what listeners think about the conversation we had. And let's think about writing this piece. Let's sit on it and think about it. I can't let you go before we do like a usual. We have to do like a quick picture because all right.
Let me take a quick picture. Yeah.
Yeah. Look in the mirror, my friend. Here you are. Okay. Now this is going to be on Twitter.
Okay. Let me just take a picture as well. Yeah.
I don't know how you take a picture. How do you take a picture on Zoom?
No, I'll take a picture on Zoom. I have a tool here. Yeah. You just look in the camera.
All right. I need to figure this out. I need to learn more about Zoom.
Oh, let's see. No. I think it didn't get saved.
I just used the plain old mobile phone. That's really what I did.
No, let me get a better picture. No, that is a snipping tool here. We can just take a screenshot of this.
What listeners are doing right now, they are witnessing two board-certified medical oncologists in Healthcare Unfiltered struggling, not having a clue how to get a picture on Zoom.
I know. True. All right.
All right, Vivek. Keep up the good work. Wonderful to talk to you, and look forward to having you again on the podcast.
Thank you. Thank you.